A lot of people die of urinary tract infections. A lot of people are hospitalized. And a lot of people suffer. It's the most common infection, I am told, by references. I believe, based on present information, that if you can measure white blood cells or see them in your urine over repeated tests with some certainty that you don't have a contaminated sample, that you indeed have an infection, that there is no normal or background level of white blood cells. How to treat that infection is also in controversy. There is something called methylene hippurate, which is available in a weak form combined with a painkiller over the counter. This is not a true antibiotic. It's more like an antiseptic. If you take that drug, it converts into an antiseptic in your bladder and will make some headway against a potential infection. But it may be more useful in that it stings. So it may be an additional way to gauge the seriousness of your infection, in that it forms another test that if you take this drug and your bladder hurts, it probably means you have some type of an infectious wound in that area. I believe probably that when you have pain like that, you need real antibiotics. And what I believe is an ideal method is to try an oral antibiotic and to centrifuge your urine with a small centrifuge that you can get on Amazon for about $140. And then you get a big bag of 2 milliliter test tubes that have a little folding cap on them that have a rounded bottom. And you test your urine. You fill it up to 1.5 milliliters, or you could try for 2. That's kind of close to the lid. And then you centrifuge it when you think you have the infection. And then after you take antibiotics, you keep doing it every day. And if your infection seems to be getting worse, you're probably not taking the right antibiotic. And then you should switch to another one. Try another 2 days or so to see if it makes it still worse. If it keeps the same or it gets a little better, then it's worth maybe keeping going and riding it out for longer. I suppose it depends on how bad your infection seems to be, whether you should keep trying for something that obviously strongly suppresses the infection. That would be good, although sometimes it might be a really powerful antibiotic that you can't take very long. So it's a gamble. You would find some old, easy to get antibiotic that's not considered to be super wide spectrum or strong. And those are the ones that you might be able to take for a long time. Something like K-Flex, but it does not mean Cipro, for example. The object of the game is not to kill it instantly, unless you're in a life-threatening situation, perhaps. Because the super strong antibiotics you won't be able to take for a long time. They're going to be undesirable because they're wide spectrum and they can cause more problems elsewhere. So the older ones like nitrofurantoin or K-Flex, cephalexin, the generic name, those are ideal examples. There's also trimethoprim, and then there's also trimethoprim with sulfate. There's also phosphomycete, which is like a powder one that you take that is also harder to get, or less common, but might be worth a try, but also an old antibiotic. And then there's penicillin-based antibiotics, various kinds of bacillins, and there's also even the tetracycline-based ones like doxycycline, which normally aren't considered to be useful, but if they concentrate in your urine, they could also work. So it's not impossible. The problem is that you may be allergic to one or more of these. For example, my father had strong reactions to nitrofurantoin and phosphomycin, like an elevated heart rate and that sort of thing, flushing, high blood pressure that was not easily suppressed with antihistamines. So that can make it troublesome to find an antibiotic that's mild, but also somewhat effective against the infection. You may have to take it for a long time and ride it out because the bladder takes something like 120 days to grow out all the cells on the bladder lining. And the infection is capable of hiding inside the cells and waiting for the antibiotics to go away. Therefore, you have to grow out all those cells, and that may take longer than 120 days. It could take a long time, at which time your white blood cells will gyrate all around and look like it's getting better and worse. And at some point, you have to hold the panel and keep the faith and just ride it out. This theory of how to do it came from a doctor and his group in London that did a lot of tests and studies and went through a lot of controversy. There's a website, which I believe is called QTIC or QT, which is a chronic urinary tract infection, a non-for-profit association that's advocating for the style of treatment roughly as I described. Although they haven't advocated for self-centrifuge, I don't know why. They just haven't thought of it. Otherwise, you have to go to the doctor a lot and get lab tests. So that's what I think is probably the way to go for UTIs, urinary tract infections. Unfortunately, it contradicts the way that the rest of the world does it, and your doctor does it. And this is all considered blasphemy because there are some fundamental errors in the assumptions of the present protocol. The present protocol assumes that the bladder is sterile and that any bug they can detect is the infectious agent. But in fact, the bladder has been shown with modern DNA testing to have all kinds of bugs in there. So it's an ecosystem. So the present protocol wants you to have a culture to find out what they believe is this single bug, which is not true. So they wait for a culture, which takes a long time. Could take a long time. Meanwhile, you don't get any antibiotics. And you may say, why don't they give you antibiotics because you have white blood cells? Well, they also weirdly believe that some certain amount of white blood cells is perfectly okay and normal and isn't really an infection. This, I believe, is completely untrue. And I have no explanation really for why they believe that, except for that it fits with their other assumptions. And there's also a movement to limit people's access to antibiotics, which is primarily based on data which does not come from the urinary tract. It's data for different types of infections where they believe that shorter courses are better and are okay. And when they do that to people with UTIs, the people feel better at first, and then their studies say that it's cured and they say that that's okay. And then soon the person has another UTI, which they label as a new UTI. But in fact, it's the UTI they had before, which was undertreated. So their self-serving assumptions with all these studies and their conclusions keep reinforcing their ideas. And as a result, people have chronic infections or repeated infections or whatever you want to call it. They are suffering. Or worse, their infection will spiral out of control and they will end up in the emergency room, at which point they'll see large amounts of white blood cells in the urine, and they'll overturn their own idea and go, oh boy, you really have an infection. We should start throwing the most powerful drugs we have at you. And they may keep you in the hospital, and you may be considered to have sepsis. And then they may give you a Foley, which is a catheter which has a balloon on the end and is permanently in you, which is another issue of the catheter tubes, because when you put a tube up there, you're guaranteed to have an infection. So you're kind of in trouble. So the catheter's main purpose is to make sure that you can pee if your system is completely blocked, which can be measured by ultrasound or touching the bladder area and the pain of not being able to pee. So sometimes you have to have it. I personally think that you should not have a catheter for diagnosis because the catheter you shove up there will create a bad infection. So in general, I'd say you pee in a cup and you do the test, and that's all you should have to do. And you should refuse the catheter unless you have some sort of issue where you can't pee at all and you're all backed up. And if you do have to have a catheter, I think you should get something like what they call a French 10, maybe by the Cure brand, which is basically the thickness that is the smallest one that seemed to be practical to get into an adult male that was as small as possible so that it was as least irritation, injury, and physical pain for the person getting it. And it should be what's called an intermittent catheter, which is, it doesn't have a balloon at the end. And it's made out of kind of semi-hard plastic. And then after draining the bladder and taking samples thereof, they should, I think, flush the catheter and the bladder out with the solution of antibiotics, which is typically a dilution of an antibiotic called gentamicin. And there are protocols about that where they're used for people who are paralyzed and can't urinate on their own and have to live with constant catheterization. And so they use this method. I think they should use it whenever they give someone a catheter because it's the only thing that works for that worst possible scenario and why you wouldn't do the best thing you could do for everyone else. Also, I cannot explain. It seems to me for their convenience. They like to do things that are fast, easy, and apparently what's good for you is not important. So it takes a lot of advocacy to get these different types of approaches.